Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
We have 3 great questions today, but before we get started, I want to invite you, listener, to send us your questions for Dr. Mingle. Leave your question in a comment on LinkedIn or YouTube, or email them directly to us at hello@minglehealth.com. Our first question today is from Karen, and Karen asks, can you give me a primer on ACOs? As our practice joins an ACO next year, what issues do you think we should consider?
Oh, good question, Karen. There's issues, important issues both at the ACO level and issues at your practice level. And it's basically looking at the same set of issues at each level. One, how credible is it that there will be savings to share? Is there data to show where your problem areas are, where the most likely areas are going to be that you can generate savings? Lacking data, is there solid logic or theoretical data that guide action that you can pretty much count on resulting in savings? And if the ACO is going to generate savings, will your practice have an achievable role in generating those savings? And as the ACO generates savings, how will those savings be distributed to the participants? Will you, as a practice, be able to benefit, and will you benefit proportionate, you feel, to your contribution to those savings? And finally, what support is the ACO offering that will help you make the changes in your practice that will contribute to the savings? As you look at the credibility that you'll generate savings, there are a few things that just make sense. First, is there easy access to primary care services in your area? Are you overpopulated, which I don't know any community that is, or underpopulated in primary care providers? Is it credible that you can encourage your patients to begin their healthcare episodes in primary care? There's some good evidence that those episodes of care that begin in primary care end up costing about half those that either begin in the emergency room or are self-referred to a specialty rather than starting in the primary care office. Another thing that simply makes sense is excessive access to expensive options tends to generate those expensive options. If there's open appointment slots in your MRI scanning unit, you tend to generate more MRI scans when lesser cost imaging will do just as well for the episode. Excess capacity in a cath lab or excess a supply of invasive cardiologists in your area can lead to higher than needed procedures, and every specialty has their examples of this. Dartmouth's microsystem design teams define indicated care, supply sensitive care, and preference sensitive care, and we often find unwarranted variation in that care that is supply sensitive. Or preference sensitive, and I think usually the dynamic with that is preference sensitive care is something that can become supply sensitive. That is, we as physicians have potentially excessive influence in helping a patient decide which option they should take. And we tend to guide them to things where we have excess capacity, where we make more money. There's some very powerful, if subtle, dynamics in the healthcare system that lead to overindulgence when that is available. Planned care in general is better than the chaotic care. If you're reinventing the wheel every time you see a patient and see this problem again, it tends to be more chaotic. We ought to categorize the common episodes of care as they present in our region, and understand how those each of those categories move through the local healthcare system. Uh, Look for opportunities to make them more each episode of care more efficient, speed recovery, eliminate duplication of efforts, and eliminate errors, eliminate complications. Um, in general, take unnecessary waits and delays out of the equation. If you have data, and I hope you will, and if you don't, look at our options. Be delighted to be helpful to you. It's not a simple matter of looking for the highest expenses. It's a matter of looking for the expensive care with a preferable option that's less expensive. Uh, and a clue to that is looking either in your system or at neighboring systems or nationwide to see where the most variation exists. Variation usually indicates that there's opportunities to reduce the cost of care by making different choices, by guiding patients in different ways, giving them the well-informed patient typically makes the well-informed patients makes the decision that's best for them. And as we can get to that, we often find that we've exerted unnecessary or unwarranted guidance to the patient and led them to to an overly expensive choice. So good luck. It's a moving target, unfortunately. Medicare rules today to establish the shared savings may not be the same as they are tomorrow. Many organizations have found that as they generate savings, the goals ratchet down, and it gets harder to generate savings in future years. Medicare is listening to that. They're changing. You can expect these rules to evolve. But at some point, you'll want to leap in, and when you can credibly perform well and help guide the system to a better future.
Great question, Karen. Thank you. Our second question today is from Jason. And Jason asks, how do you recommend optimizing quality scores for ACOs using MIPS CQMs?
Great question, Jason. I think the first thing to remember is we change what we measure. So you need to measure, and you need to track your progress at the right interval. Too infrequently, and you don't have any opportunities to improve. Too frequently, and you have excessive opportunity to meddle or fiddle, and you might say oversteer your system. So I'm inclined to think that for most improvement programs, monthly or quarterly data is probably ideal. Now, daily or weekly can work. A daily or weekly process has a couple of advantages. Daily can turn your quality feedback into gaps in care feed forward. So that same reporting that generates the quality reports and monitors your quality can be used to improve your care, which is great. But you need to have the discipline not to fiddle with the data if you're looking at it frequently. Use it to recognize crises when they occur. Use it to recognize opportunities to serve. But recognize that random variation is always there. So if you're too responsive to day-to-day changes in your quality measurement, you may take some of the effectiveness out of your quality improvement program. I love time-oriented statistical control charts. Combine that with a disciplined analysis to watch for special cause variation. Then you can keep from overreacting and engage your teams in a great process. Now, not all problems uncovered by your measurement are going to be defects in the quality of care. There's a flow to every care process. There are questions of who does it, where the great best data comes from, who collects it, where it's documented. Can you get the data with simple queries out of your system? How easy is it to recover? So you want to start by setting up a measurement system. Uh, and I think expect that some of your measurements are going to be empty, going to be way off. But if you need to start to measure sometime and then try to figure out why, whether it is off and why it's off. So you watch and learn. First, you measure, then you audit those measurements, and you don't have to do an enormous audits, 10 looking at 10 patients to compare to their quality scores, look at the charts, see on your manual audit how they fall and see if it matches the quality scoring. If you pass those first 10, extend it to 30, and then keep periodically auditing to adjust your workflows, adjust your training, adjust your templates, and then repeat the process. And this is going to be a continuous learning process. And some of my clients have been engaged in this for a decade now. That they continually find the reasons that their templates don't that their documentation workflows or the templates they're documenting in are not bringing the desirable data into their quality reports. So you'll be improving your system, and that system is made up of people, processes, and technology. And look for ways to put the right people in the right jobs, give them the training they require to do their jobs, adjust the processes, your written or unwritten processes and procedures, and make sure the technology is configured. All technology is flawed, but most of it can be configured to help you do a better job. And recognize I like to watch three general rules for my continuous system improvement. Your aim is to standardize. Try to get everyone in your system doing things in the same way. You want to simplify, reduce steps when you can, make the decisions simpler, remove complexity every opportunity you have, and integrate. You need to make choices that bring your care into closer collaboration and coordination. Your healthcare system should be operating like a well-tuned machine that you recognize the problems quickly, you move them on quickly when indicated, get them to the right initial treatment when you can be the end of that chain. Always work on eliminating waste and delays. And get started now. The sooner you start, the sooner you see benefits. It's going to be a competitive process. You want to perform better than your neighbors, and expect it to be continuous. You'll never be done looking for the problems and correcting them.
Excellent question, Jason. And our final question today is from Amanda. And Amanda asks, can you provide a deeper explanation of data completeness? It's still a little confusing.
As I look at the reasons for confusion, I see that it seems like a simple concept, but it has some subtleties that make it particularly confusing. I'll try to get around that with this explanation. Let's start with a definition. Data completeness is represented in quality reports as the reporting rate. So you can see the reporting rate and data completeness are synonyms. Generally, when you're reporting quality to Medicare, you're reporting a, a, a performance met rate, a performance not met rate, an exclusion rate, and a reporting rate. So it's deficits in that reporting rate that can harm you under the data completeness rules. 100% reporting rate is data that is 100% complete. A 50% reporting rate means you're reporting data on only 50% of your eligible instances, and it does not meet the 70% the data completeness requirement. Now, Medicare expects that you can't always have access to all your data. So they give you a little wiggle room. I think when these reporting systems were set up, the most common reason for lack of access to data was that not everyone had been moved to from a paper chart to an EHR. Now that's still true, but more people are in EHR now than when things got started. The other thing they recognize is that your best data does not always come from the legal medical record. Sometimes it makes more sense to go after it from a derived or a parallel process, like a tumor registry or a diabetes registry or a surgical log or a vaccination log or one of those many external lists that we maintain. So, and Medicare assumes that if it's not the legal record that it's coming from, there may be holes in the data. So there's different ways you as a registry, if you're serving as your own registry, or your vendor should be dealing with this, depending on that source of data. Medicare has told us if your data is coming from the legal medical record, your assumption is missing data indicates performance not met. Now, there's some variation in that with inverse measures, but let's ignore inverse measures for a moment and just say, in general, the lack of data means performance not met. The for instance is, think about flu shots. I should know who's from my billing data, and everybody has billing data because everyone generates bills for their work. You should understand from your billing data which of your patients is eligible for a flu shot. And to understand your reporting rate, you have to know what your denominator is. You have to know how many patients, which patients are eligible for that flu shot. Then when you look for the data, and we generally look in the clinical data for flu shot records, we find those that have had flu shots. So if you're looking in that legal record and you find a flu shot, that's performance met. And we're going to ignore exclusions for the moment and exceptions. So let's just think of met and not met. And if you don't find evidence for a flu shot, your best data is telling you that patient does not have a flu shot, so you can list those as performance not met. Now, if you're looking at a derived data set, Medicare says you can't really count on the entry being there. So a lack of data means a lack of reporting. Instead of a deficit on the performance, you deficit on the reporting. Now, that can be good for you by giving you a higher performance rate at the expense of your reporting rate. But if your reporting rate ends up getting below 70%, then it's not a valid report. Let's give you 3 examples to illustrate this. Let's say you check your billing data and find that 100 of the patients you saw last year were eligible for a flu shot. Now, first option is to manually or electronically search your legal medical record for the flu shot. Generate a report looking for a yes or a recorded date if they got the flu shot elsewhere. So you find 50 patients with a recorded flu shot, and those 50 are performance met. 50 patients have no flu shot recorded. So to the best of recorded knowledge, those patients did not have a flu shot. Because the numerators came from the legal medical record, the reporting rate is considered. Medicare assumes a reporting rate at 100% if you're doing a search of the legal medical record. So the missing data represents performance not met. Got a 100% reporting rate and a 50% performance rate. Now, let's think about a different practice with that same 100 patients eligible for flu shots. In this different practice, I'm keeping an immunization log that I judge to be the best source of data. So it's not in the legal medical record; it's parallel to that. It's in my nurse's station, and whoever's giving the shot, I expect to record in that log what immunizations are given. So my staff records that they gave a flu shot to 50% of my patients. But since this is not the legal record, I can't assume that everyone who's received a shot was given. Maybe there's a day we were busy and short-staffed, and they neglected to complete the immunization log. Also, there's the dynamic that if I've asked if they've had a flu shot and they say yes, we're not recording that in the log. It's recorded in the medical record, and I'm not retrieving the data for the report. So in this case, the missing data is considered a lack of reporting, but not necessarily performance not met. So my performance rate for the 50 I see, the 50 that are in the record, the performance rate is 100%, but the reporting rate is only 50% and fails the 70% data completeness requirement. For the final example, let's consider an ACO in an evolving community health system. There are 10 practices that are banded together in this case, each with a different medical record. Data is accessible for 6 practices, but inaccessible in 4, either because it's paper and they're not able to abstract the charts, or there's technical reasons, a lack of people with skill, or a vendor a contract that prohibits access to the core data. So each of our 10 practices have 10 patients eligible for flu shots. In the 6 practices with accessible data, I find 5 flu shots in each, giving us a 50% performance rate. And in those 6 practices, 100% reporting rate. But 4 practices can't supply data, and we don't know the flu shot status on the 40 eligible patients. With 60 patients in the accessible reported group, 40 with data inaccessible, we end up having a 50% flu shot performance rate. But we failed data completeness because we were only reporting on 60% of the patients. The 40 patients that were in the practices with inaccessible data drop our reporting rate. So, final note on data completeness: really, you can spend your 30% data completeness allowance on anything, whether it's because data is in paper charts and hard to get, or it's EHRs that you don't have access to, you don't have the technical skills to run the queries, whatever. Medicare doesn't care. What they do care about is gaming the system, or cherry picking. They don't want you to drop the 30% of patients with performance not met, so you elevate your performance rate. Anything that is unbiased that you're dropping for other reasons of accessibility is fine, but they'll get upset, and if they have the freedom to push back at that or disallow the measurement, they will take that.
That was an excellent question and answer on data completeness. Thank you, Dr. Mingle.
Thank you, Kyle.
Karen and Jason, thank you as well for your excellent questions. If you have a question for Dr. Mingle, please leave it in a comment on LinkedIn or YouTube, or send us an email at hello@minglehealth.com. And thank you again, Dr. Mingle, for sharing your insight with us today.
Thank you, and thanks to the contributors for all the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.